TIM3 or TIM3, T-cell immunoglobulin targeting mucin 3, TIM3 essentially is a immune checkpoint that is found on the surface of both T cells and myeloid cells. The expression of TIM3 appears to be correlated with the development of an immune exhaustion phenotype. And preclinically, it appears that blocking TIM3 appears to increase T cell function. Very interestingly, provocative data from the group by Brian Raffel has also demonstrated the role for TIM3 expression on myeloid cells, suggesting that the blockade of TIM3 can not only reverse T cell exhaustion, but it can also improve antigen presentation by myeloid cells. And again, I highlight that this data is preclinical, but it's very, very promising, and a couple of great papers about it. The TIM3, to study this, several different companies have developed novel antibodies that are looking at blocking TIM3. The antibody that we're discussing is the antibody Cobolimab, and this is being currently studied by GlaxoSmithKline GSK in the context of several different programs. The programs of which we want to highlight is AMBER. Now, AMBER is a clinical trial that studied Cobolimab in its initial dose escalation, both singly and in combination with anti-PD-1 Dostarlimab, which is an anti-PD-1 inhibitor. And in the data that we are presenting is from the Part 2B cohort, which is the dose escalation and expansion study of Cobolimab and Dostarlimab in patients with advanced non-small cell lung cancer that were refractory or had relapsed following prior immune therapy with anti-PD-1 and anti-PD-1 combinations. And in this clinical trial that we're presenting, we have a total of 84 patients who have been dosed with TIM3 and Dostarlimab at a variety of different Cobolimab dosing levels. These include Cobolimab 100 milligrams, Cobolimab 300 milligrams, as well as Cobolimab 900 milligrams. The recommended phase 2 dose is Cobolimab 300 milligrams. 60% of patients had more than 3 prior lines of therapy, and the commonest histology that we studied was adenocarcinoma, 70% of patients, and squamous cell carcinoma, 26% of patients. What we observed was that in the patients that were treated, we observed a response rate of about 10% in the Cobolimab 300 milligram dose level, as well as 7% in the 100 milligram and 7% in the 900 milligram dosing level, for a total response rate of about 8.3% out of the total of 84 patients that were disease evaluable. It is important to keep in mind that these responses were durable, because when we looked at the progression-free survival of these patients, the progression-free survival that we observed was certainly quite durable in these patients, with some sustained responses over time. Correlative analysis demonstrated that responders had higher expression of TIM3, that is a target within the tumor by IHC, compared to patients who had progressive disease. And certainly this combination is safe. So what we like to stress is that based on the findings shown here and reported previously, there's clear evidence that the combination of Cobolimab and Dostarlimab is safe. There were no DLTs. The pharmacokinetic, pharmacodynamic data support that TIM3 is having its desired effect in terms of T-cell engagement. And clearly, at the Cobolimab 300 milligram dose level, we have seen that there's sustained target receptor occupancy, as well as some evidence of efficacy, and this is the current recommended phase 2 dose. The conclusion that the combination appears to have some preliminary signs of efficacy in patients with advanced non-small cell lung cancer that were relapsed or refractory to checkpoint inhibitor therapy. And the combination is being evaluated in several ongoing trials, including the COSTAR trial, which is an ongoing phase 2 study, phase 2/3 study for patients with refractory or relapsed non-small cell lung cancer, in which the combination of Cobolimab, Dostarlimab, and Docetaxel is being compared against Docetaxel, as well as Docetaxel alone, in a trial that is ongoing and that is expected to read out.